Hello, and welcome to this episode of A Cancer Conversation with the Georgia Cancer Center at the Medical College of Georgia at Augusta University. I'm Chris Curry, your host for this podcast. In this episode, we're going to be talking about Burkitt Lymphoma. Joining me for this conversation is Dr. Ayushi Chauhan. You are an assistant professor and medical hematologist-oncologist here at the Medical College and the Georgia Cancer Center. It's a pleasure to have you on today.
Thank you so much for the introduction, Chris, and it's lovely to be here.
So let's talk a little bit about you. I like to give people sort of an understanding of the guest and their background and their passion for medicine. So let's talk a little bit about how you chose this career working in blood cancer, working with patients, and why was that the right opportunity for you?
So sometimes in medicine, I feel that the specializations are a problem of plenty, rather, because I think that all fields in medicine are super interesting. So I think it's part serendipity and part a developing passion. When I was in residency, everything just was, so new, and there's so many, the more in depth that you go into a field, the more interesting you find. And for me, it just happened that we had a lot of exposure to cancer patients during our residency. We had a cancer center. As medicine interns, we were rotating on the cancer service.
Okay.
And I thought that cancer patients represent a very unique population among all of internal medicine, because you're not just going to tell a cancer patient, okay, I'm going to deal with this one problem and going to ignore everything about you. Mm-hmm. You become essentially their primary provider once you start treating their cancer, and you end up treating almost everything else. So it's a unique opportunity where you're helping patients who have, the big C word, mm-hmm. but you're also able to take care of all other systems, and you do have to know that, because a lot of things we are doing are going to affect their heart, their kidneys, their lungs. So you can be a cardiologist, a pulmonologist, a hepatologist for these patients, and also their psychologist. You get to be involved with their families. We know about their in-depth details, and it's just such a unique immersion into a person as a whole, and not just their disease, that I found it fascinating, and I just never looked back.
What is it like to work with these patients? How do you sort of approach their care? What's your philosophy working with them? Because like you said, you're not just dealing with their cancer, you're dealing with everything else too.
Yes. So, and it's a tricky situation sometimes, especially in lymphomas, because I just specialized in I just do lymphoid malignancies. My philosophy is always teamwork. The patient, their family, their goals, and me, we are part of the team. So we are equal decision makers in that.
Yeah.
The tricky part is that sometimes you don't have multiple options to give.
Yeah.
So it's part very dictatorial, that when they come in and they have an aggressive lymphoma, you have to tell them that okay, it's going to be A, B, C, and D.
Okay.
Unfortunately, this part is non-negotiable.
Okay.
Right? The tricky part becomes how to make patients feel like they're still equal decision makers, despite a lot of the power immediately being taken away from them, just because of the aggressiveness of the disease.
Yeah.
So the way we work around it, I think that it becomes a little bit, it's a more difficult balance for the aggressive lymphomas, because you do know if you don't start chemotherapy, the patient is going to die.
Yeah.
For the slow growing lymphomas, it becomes easier, of course, because you know that we can make a plan and sort of like see how things are going and change things around. For the aggressive lymphomas, it's a little bit more. It becomes a little bit more psychology, that, look, I know you're not feeling all the best right now, but we are just crossing the stormy sea. We can see the oasis. It's right there. Let's just get you through that.
Yeah.
But I believe teamwork is key.
And I want to ask you,
weird sometimes.
Yeah, I want to ask you something before you get too far, because you talk about it. about taking that power away. And I feel like in today's society where everyone Googles everything or uses Bing for everything, you probably have run into them where they have a list of things that they read. And so how do you navigate that in knowing that you have to be aggressive with their care?
Yeah, and for the most part, I think that, our I love it when my patients have already read up about it, because I do believe that medicine becomes this sort of unequal thing, an unequal power balance sometimes. So I actually don't mind, even if they have read the wrong thing or if they have read something that is not applicable, because at least they are invested and they're asking questions. And I have not really run into the issue where patients have disagreed with a plan,
Okay.
especially in aggressive lymphomas,
Okay.
just because of something they've read. They will ask the right questions. For example, one of my young patients, she has diffuse large B cell. So it's a type of aggressive lymphoma. Her disease is particularly aggressive and has been resistant to chemotherapy. So her mom asked me the other day, you know what? I read about proton therapy. What is that? And I said, well, I'm glad that you read about it. It's a type of radiation therapy, and that's not really what we are doing for your daughter right now. We are really just trying to focus on more immune-based therapies and cellular therapies for the lymphoma, but I'm glad you read about it. So typically, I think the questions are very well-meaning, and it shows that these people care. I think that they just, they care about their family members. I've never run into obstruction because of it.
Yeah.
I think it just leads to a more productive discussion.
Yeah, that's awesome. So talk to me about Burkitt lymphoma. I've heard of Hodgkin's and non-Hodgkin's lymphoma before, but I had not heard about Burkitt lymphoma. So what is it? How common is it in the U.S.?
So, the great question, Chris. So, Burkitt is definitely a rare lymphoma. So, it is a type of non-Hodgkin lymphoma.
Okay.
And it's a very fascinating disease. I think a lot of advances that we have made in the world of hematology and lymphomas are actually attributed to Burkitt lymphoma.
Okay. How so?
So, yeah, I'll tell you. So originally, this was described by this guy called Dennis Burkitt when he was stationed in Uganda as part of the Peace Corps.
Okay.
And he noticed that a lot of the sort of the African children in the sub-Saharan regions, they would present with this almost like a wasting disease, and they would have these huge masses in their neck, in their jaw, and it just almost like deformities. And he published the case report, like the case series on this. As a segue, Dennis Burkitt became known as the Fiber Man. He became known for his role in dietary fiber. Never really he became more famous for that.
Oh,
but,
wow.
But the disease is after him, so we all remember him. But strangely, during his career, he was known for dietary fiber. But that's an aside. So that's how it was discovered. Also, it was the Burkitt lymphoma cells that we discovered the first virus that causes cancer, which is Epstein-Barr virus.
Okay.
So a lot of first to Burkitt lymphoma, and sort of fascinating sort of history of it. Now, how common it is in the United States. So it was first described in sub-Saharan Africa, and that's where sort of it's prevalent. In the United States, there are only about 1,200 cases in a year.
Okay.
So you can imagine how rare that is.
Yeah.
However, it is definitely more common in children. So
Okay.
children who are younger than 11. There are certain high-risk populations. So patients who are suffering from the human immunodeficiency virus, or HIV, they are definitely more prone to it. But we do see sort of a mix of people. Some who don't have HIV at all, who still have Burkitt. It's typically a disease of the younger person. So younger person is, most of my young patients will be, who are not HIV, they're typically in their 30s.
Okay.
And they're typically men. Patients who have HIV can develop Burkitt lymphoma sort of at any time in their trajectory, but it's all related to the fact that somebody whose immune system is not functioning at at 100%, they could have a genetic problem with immune deficiency. They could have the HIV virus. They could have other problems. They are more prone to develop Burkitt. But overall, still a very rare disease.
Do you see it in certain parts of the United States more often than others?
So I don't think that there's necessarily a geographic restriction unless you somehow practice in an area where HIV is just more prevalent. So, for example, I trained at Georgetown in DC, and just because it's a urban area, we do have just a lot, we do have a vast population, and we do tend to have these concentrations of HIV, and so you definitely see more Burkitt there. But other than that, it's pretty what we call sporadic. So you can't really find these hotspots, so to speak.
And are there any genetic markers that you can look for? I know we talk a lot about genetic testing before on this podcast. Are there any sort of genetic things connected to Burkitt lymphoma?
So that is an area of study, but unlike breast cancer where you have this BRCA gene and some other genes, there's no real genetic mutation that will make you predisposed to Burkitt. Now, if you have a genetic mutation that causes immune deficiency, for example, like common variable immunodeficiency syndromes, then you're more prone to develop Burkitt. So that would be the only situation where we would be looking at some sort of a hereditary marker for Burkitt, but rather we focus on what it looks like under the microscope, what the stains that we are doing, and it has a very characteristic appearance. So we typically focus on that, and definitely every person who comes in, we test them for 2 viruses, HIV and EBV, which is Epstein-Barr virus. So we our management doesn't really change, but at least if we find out, and sometimes we do have these sort of nasty surprises where patients find out that they have HIV at the same time as Burkitt, then the reason for testing is to make sure that they can get on the right medications at the same time as chemotherapy. So that's more what we are looking for rather than hereditary genetics.
Talk about that first appointment. If someone walks in to see you and maybe they were referred by their primary care provider, what does that first appointment, sort of that beginning process, look like?
And this becomes something I do want to impress upon patients, that the first appointment can definitely be very overwhelming, because Burkitt lymphoma is one of the most aggressive lymphomas. It's actually one of the most aggressive cancers, where the tumor can double in size in 24 hours.
Oh, wow.
So if you watch it, you can see somebody's neck mass or swollen gland grow in front of your eyes. And many times it is diagnosed in the hospital, in the ICU, rather than even somebody coming to clinic, because they can actually present with some serious electrolyte problems related to the tumor. But aside from that, we do have patients who come in as an outpatient once they've been diagnosed. Thankfully, and this is something that's unique to our cancer center, we have a great relationship with our community providers. We respect them a lot, and hopefully they trust us enough to keep us in the loop. So most of the time we know when somebody with this aggressive malignancy is coming over, because the provider has sort of texted us or informed us that, hey, I diagnosed this. But the first appointment can be overwhelming, because a lot of the times we need to move on very quickly. So blood work will be done at that first appointment, but right at that time we will be setting up for a PET scan if that hasn't been done, or CAT scans depending on the situation. We will already be talking about the chemotherapy at the first appointment, so information will be given about that. And frankly, we will sign the chemotherapy consent that very first day, and even have a date for getting admitted to the hospital.
Talk about being that patient's support system. You talked about that a little bit. Talk about what that's like for you, because not only are you dealing with cancer in general, but you're dealing with all the other range of emotions and reactions. So how do you handle that as a physician?
Sometimes it can be quite emotionally draining, because that the patient does not have any other support system. Fortunately, I have a great team. We have social work, we have psycho-oncology, my nurse navigator. We make sure the patient has all these numbers uh, so they can get in touch with anybody in real time when they need to. They have the after hours number. But each visit, I think, we just need to spend a time. We just need to spend more time talking about it. Uh, each situation is different. Some patients are handling it better than others. Sometimes I'm handling it better than others, right? Like better than other times. So, no perfect answer, but I think that if you're genuine and the patients understand that, I genuinely, we are physicians, we don't hold this against them. They have a free space to vent and talk, and I tell them that, and I don't mind saying the words that this is a crappy situation.
Yeah.
There's no barriers between us, no barriers of jargon and stuff. I said, this is a crappy situation.
Yeah.
There's no other ways around it. No platitudes will work. So you just try to be as real and genuine as possible and hoping that works. Sometimes it works, sometimes it doesn't, but that's the path I take. And, so far it seems to be working for most of my patients.
That's good, yeah. Everybody wants to know what to look for. What is that red flag? But I know you and I were talking before we started recording, and you said that with Burkitt lymphoma, a lot of time it's red flags all the time. So what does that look like? What does that mean?
Yes. So as I said, sometimes it's not that, so many of my lymphomas are, I was feeling fine. I noticed a lump on my neck. I went to my primary care. They asked me to come and see you. We did a biopsy, and it's a different type of lymphoma. For Burkitt, patients get sick really fast. And everybody's definition of sickness is different depending on where the Burkitt is. So there will be patients who definitely have that enlarging mass somewhere that is definitely getting bigger in front of their eyes, so they're concerned that they're going to their primary care physician, who will appropriately send them to the hematologist or for a biopsy or do some scans at least. There'll be patients who don't really know what's going on. They will be having fevers, and people will give them antibiotics. The fevers don't go away. They will be wasting away. They'll be losing weight. And I'm not talking like a couple of pounds here and there. I'm talking 10, 20, 30 pounds of weight.
Wow.
They'll be having drenching night sweats. They're soaking their bed sheets, their pajamas at night, and they don't really know what to do. And many of the times, thankfully though, somebody will either take them to the emergency room or force them to see the doctor. But these are the signs typically, and it happens fast. One of my patients, completely fine a month back, and then just started having nausea and vomiting. Wouldn't go away. Went to her primary care physician. They gave her some medicine, said maybe it's a GI bug. It'll get better. Not going away. She's losing weight. Feels bad, but you can't really point your finger on what's making me feel bad. Of course, I'm nauseated. Ultimately, had to go to the emergency room, and this is a span of 3 weeks. A completely functional, healthy person who doesn't really need to see the doctor, who ends up in the emergency room. They do an upper and lower endoscopy just because of how much she was throwing up, and her stomach was all full of Burkitt lymphoma. And that happens. Burkitt lymphoma tends to involve the gut. So it could be anything. Another guy of mine, a young guy, working and just is feeling sick all the time, can't work, very, very tired, having sweats at night, is not eating, is losing weight, and they don't know what to do. They do take him to the primary care doctor. They get some scans done. There's some masses here and there, don't know what it is, goes to the hematologist. But these are the typical symptoms. Most of the time, it's going to be quick, though. And it's not going to be something that's going to be happening over months or weeks. It's going to be something that can happen over 2 or 3 weeks. Or within, like, they can be fine a month back, and within a month they are in the hospital, half their body weight. So a lot of these it will be an egregious symptom. It's not going to be something that is simmering. It's something that's already boiling and it's like spilling out of the pot.
Yeah, yeah. What are some common questions that you get asked by your patients about Burkitt lymphoma, and what kind of answers are you able to give them?
So I think that, a big question is, how did I get it? So if they have HIV, that's unfortunately the answer for most of them. But for those who don't, as I said, there's no heritable marker. So I tell them that my answer is going to be unsatisfactory, was just bad luck.
Yeah.
I wish sometimes they want some gene to be wrong, rather than, I did everything right my life and I'm doing everything right and suddenly I had this.
Yeah.
So that's one common question. What stage is it? That's another common question. And I tell them that staging is important to a degree, but all stages need chemotherapy and all stages are curable.
Okay. That's
Some
good
to
to
a
know.
higher degree than others.
Yeah.
Of course, more advanced stage, your cure rates are going to go down by about 5-10%, but still curable.
That's still really high, though.
Yes. And big thing is, can you just take this? Can we just take it out? Can we just zap it, right? Can we do radiation or proton or whatever they've heard about? And you have to tell them all lymphomas at the root of it are blood cancers. So what I tell them is you don't have to think of it as a solid mass. You have to think of it as a liquid, a river flowing through your body. Even though it looks like a mass, it's really flowing through your body. Mm-hmm. So any type of surgery or any type of radiation is like playing whack-a-mole. Something is going to pop up somewhere else.
Yeah.
So treatment has to be something that goes through your veins and goes all over your body. Mm-hmm. So it has to be chemotherapy. Because it's rare, but we do have early stage Burkitt where they just have a few swollen glands in the neck, and we have fortunately caught it. And they're like, do I still need intensive chemotherapy? And unfortunately, the answer is yes. It is curable because of intensive chemotherapy. So that is the non-negotiable part, whether they're stage 1, whether they're stage 2, 3, or 4. Mm-hmm. And I do have to tell them because, Chris, remember that blood cancers, and particularly lymphomas, are less than 30%. 70% of the cancers out there are going to be breast cancer, lung, colon. Mm-hmm. So they have had experiences with those cancers, right? Mm-hmm. My friend had breast cancer and she was stage 1 and she was fine. My other friend had breast cancer, it was stage 4 and she died. And that is the point that we have to sort of differentiate between, that even though this lymphoma is looking like a mass on your CAT scan, even though you have masses in your, wherever it may be, your liver, your gut, your colon, it is a blood cancer. It's a liquid river that is flowing, so it has to be chemotherapy. But the counterpoint is that stage 4 is not going to be a death sentence. Stage 3 is not going to be a death sentence. Stage 1 and 2 are not going to be a death sentence as long as we make it through chemotherapy.
Yeah.
And the big difference between the early stages and the later stages is the number of cycles or rounds of chemotherapy that they need.
Okay.
So advanced stages need more rounds, about 6 rounds. And earlier stages, you can get away with 4 rounds. But it's really the number that you can get away with, not the fact that you need chemotherapy.
Okay. For patients, when those patients get on chemotherapy, what should they expect? What does that look like? Because I know chemotherapy can come with a lot of side effects. We're having to be aggressive because it's an aggressive cancer. So what does that process look like?
And that's a good question, Chris. So this process will be a little bit more intensive than other chemotherapies. And most of the time, it does require getting admitted to the hospital each time for chemotherapy. There are other types of lymphomas. There are other types of cancers where you can go up to the infusion center, sort of sit in a chair and sort of work on your laptop while you're getting chemotherapy. But a lot of the time, the Burkitt lymphoma chemotherapies, you'll have to get admitted to the hospital. Chemotherapy will also be given through the spine in addition to through the vein. Because one thing that Burkitt lymphoma tends to do, it likes to try and get to your brain. So even if you don't have that in the beginning, we will, of course, do all the testing. We still have to give a preventative dose of chemotherapy through your spine. None of this will hurt, but the biggest risk factors of these chemotherapy regimens are really going to be low blood counts, tiredness, and risk of infection. So, most of the time, between your hospital visits, which is going to be every 3 weeks, you're not just staying at home, sort of suffering in silence. We actually have a game plan where our patients are coming to the clinic 2 times a week. They're not necessarily seeing me, but they're getting blood work done. They have an infusion chair appointment in case they need blood transfusions, but we are keeping a close eye on it. The biggest thing to manage during these chemotherapies is infections. And that is the biggest side effect of the intensive regimens. So I tell my patients to always have a thermometer at home. In fact, I tell them get 2 thermometers, make sure that they are working, their readings are matching, and we give them extensive education on how to identify an infection. And with the caveat that in this situation, we will most likely shoot first, ask questions later. So if they do have a fever, we will ask them to come to the emergency room, get antibiotics, get looked at immediately, even if it turns out to be nothing. But this is the hypervigilance precautionary mode that helps us prevent some of the side effects of these chemotherapy. As for nausea and vomiting, I tell my patients, this is not the 1950s, 1940s chemotherapy. You're not going to be like throwing up in a bucket. And what I do tell them, and I will stand by it on camera, that if they're having bad nausea and vomiting with this chemotherapy, it's my fault, not the chemotherapy's fault, because we have so many medicines in our arsenal that you tell me and I need to up the ante. So that's what I need to do. So they should not be suffering with these side effects.
Okay.
Not that it's all rainbows and unicorns, but it's not going to be puking in a bucket all the time.
Yeah.
If that's happening, I'm not doing something right. So I need to be held by the collar, and we need to do better for you.
So it really is a back and forth. You talk about that balance of power, but they need to be telling you things just as much as you're telling them, especially
Yes.
when they get onto the chemotherapy.
Yes, and what I do tell them is sometimes our patients are really very nice, right? They actually don't want to burden you. So what I tell them is the burden of proof is not on you, it's on me, because I know what to look for. So what you need to do is tell me anything and everything that's going on. And I will assess what is okay to be watched and what needs intervention right now. And that's why we see them during, before, and after each chemotherapy. And one thing that we do is, hey, what went right the last cycle? What went wrong? Did you have bad nausea? What was going on? Let's see, do we need to go up on that? But I think that, as I said, that this is one way where we try and minimize that power imbalance, because they don't get a choice of chemotherapy, right?
Right.
I have to decide the regimen. I
Right.
have to tell them that this is what it's going to be.
Right.
But what they can do is just tell me all symptoms, and I'll tell them, okay, that sounds like it could be something else. Let's figure that out later. Okay, this sounds like it could be from the chemotherapy. Let's fix that. So one thing that is critical is the patient should not feel they have the burden to decide what is serious and what's not. All we tell them is, you tell us everything, 1 to 10, whatever symptom you're having. And we will have the burden of proof on us to see what needs immediate attention and what can wait.
And it really is individualized care. We talk about that a lot with all of the different cancers. You talk about their sister or brother or whatever with breast cancer, prostate cancer, et cetera, and having that history. But it really is so individualized. Obviously, having to have the chemotherapy, not individualized in Burkitt, but the side effects and the way that you manage the side effects and everything, it is really individual to each patient.
Exactly. And how a person reacts to that chemotherapy is also different. So you can have somebody who's super young and who's dealing with it, who's sailing through the chemotherapy, even if it's intensive. And then you have somebody else who's maybe a bit more older, maybe a bit more frailer. And so you have to have a game plan that, okay, we know that they might get dehydrated because their appetite won't be great. So even without them asking, let's set them up for chairs like 2 or 3 times a week so they can just come and get IV fluids without having to ask for it or without having to get to the point where they have to call the emergency line or call the nurse to get it set up. But in this fashion, yes, we do individualize it.
That's awesome. Well, Dr. Chauhan, I appreciate your time today sharing this information with those watching and listening. I always appreciate, your time and everyone's time because I know that y'all have a lot going on, obviously very busy, but, segments like these, podcasts like these, episodes like these are so important because what we're talking about is empowering people, giving people knowledge, giving people information that they can use, that they can better understand what's going on in their bodies if something is going wrong.
Definitely, Chris. I think that the more people are educated about it, and as I said, they don't have to understand it completely, I think it helps them take charge of their own health, and I think it's very important. So I really appreciate the work that you guys are doing.
Well, thank you so much, and hopefully we will talk to you again. You're always welcome on the pod anytime there's a topic that you want to talk about.
That sounds great, Chris. I look forward to talking about there's so many lymphomas, right?
Yeah.
We can tackle each topic as it comes. So
all right.
Thank you so much.
Absolutely. Thank you all for watching and listening. Remember to subscribe to A Cancer Conversation on the Georgia Cancer Center's YouTube channel. You can also watch the video version on Spotify. If you are an audio listener, you can listen on Spotify as well as Apple Podcasts, Google Podcasts, or even Amazon Music. Just search for A Cancer Conversation or Georgia Cancer Center. And remember that A Cancer Conversation is produced by the Cancer Center at the Medical College of Georgia. It is directed and edited by Lindsay Morris. Thank you very much for spending part of your day with us, and we hope we will see you on the next episode.